get to those once we're done the presentation. And we're going to give a couple more moments. We had a big registration group today. So we're just going to let everyone join, but also be courteous of everyone's time. And I apologize, my screen is not on because my computer is being finished.
Yeah, and your voice is a little, we can hear it, but it's a little digitally.
Yeah, I need to restart. I'll let Sharon take it in a couple seconds here. Again, welcome. I'm going to go ahead and hand it off to Sharon since my computer's acting a little weird. So Sharon, you're welcome. I'm here to flip when you're ready.
Thank you, Heidi. Welcome to the Community Enrichment Series. We're doing your guide to accessing services across multiple programs. We can go to the next slide. So ground rules, we are recording the presentation. When the presentation's done, we'll turn that off so the questions and answers will not be recorded. Please remain on mute unless you're asking a question later. Please use chat to submit questions and we will address them during the Q&A. This is a safe space, no judgment. Participants agree not to share personal information or opinions shared within the group outside of this discussion. And please silence your cell phone just in case you're not on mute and something comes through. And slides, documents, and unanswered questions will be emailed after the presentation. Disclaimer, so this is intended for informational purposes. It's not intended to determine eligibility. We do not determine eligibility. The state and other entities decide that. So this is just informational purposes from our experience. So my name is Sharon King. I'm the Senior Vice President, Population Health here at the Coordinating Center, which means I oversee all of our programs here, either directly or indirectly with the directors. I'm a nurse and I've been at the Coordinating Center now for 33 years. So I started as a model waiver coordinator, and that was the only program we pretty much had at the time. So I have helped to implement each one of these programs that we have now. And that's where my knowledge is coming from about these programs. Objectives, you learn the differences in the various Medicaid programs. You understand when you can and cannot be in more than one Medicaid program, and you'll gain insight into the possible advantages and disadvantages of being a participant in more than one Medicaid program. The programs that we have here at the center, we have in our care management division, REM, which is Rare and Expensive Case Management Services program. That gets confusing because REM, I hear Rare and Expensive Medicaid, Rare and Expensive Medicine. It's really REM stands for Rare and Expensive Case Management. They took this C out because that would be RECM, and that would not be a good acronym for a case management program. So it is REM, Rare and Expensive Case Management. Model waiver. Community Health has our homeless support services right now. I won't be presenting on them today because they're not necessarily programs. They don't come with services. They're in 2 different counties. We have one in Montgomery County, one in Howard County, and it's for the chronically homeless. And we help them as they're getting housed. And in service coordination, we have autism waiver services, and we provide that in 5 counties now, almost 6. We do Hartford, Howard, Dorchester, Worcester, Queen Anne's, and looking at another one. And then what we call community first programs. We're not the only agency that provides the service coordination for that. So that's what we call it. Some other agencies call it support planning services, but it incorporates community options waiver, community first choice, community personal assistance services. And there's increased community services, which I won't really be talking about. That's a small program for those that are in a nursing facility, but for some reason they don't qualify financially for the community options waiver. They still have to be able to choose to live in the community using Medicaid. So it's this kind of little program that catches those people so they can still move out into the community. But you wouldn't apply for it. You would apply for community options waiver. And if you weren't eligible, they might put you in ICS. And then DDA, Coordination of Community Services for DDA. And then our newest program, the Medical Daycare Services Waiver Program. So first I'll talk about eligibility for each one of these programs. Model waiver is for, so if I tell the story of how model waiver started, it kind of explains a waiver. So Katie Beckett, way back in the early 80s, Katie Beckett was an infant who got an infection in her brain, and that affected every system in her body. So she was hospitalized long-term, and she was living in the hospital. So when she was a toddler, her mom wanted to bring her home. That was unusual back in the 80s for one thing, but she was willing to give it a try. Katie, at that point, she was on a ventilator when she was sleeping, but that meant that she had a trach all the time, and she was G-tube fed, and she had some mobility issues. So her mom wanted to bring her home, but because she was living in a hospital, that was her residence, and that qualified her for Medicaid because it was based on her own income and assets. She was an infant when she got sick. She didn't have any. So once she went home with her family, she would no longer qualify for Medicaid. So she was stuck in the hospital. So Katie's mom took it all the way to Washington, and it was Reagan at the time. And he said, this doesn't make sense. Medicaid's paying for a hospitalization long-term because they'll lose the Medicaid when they go home. It would be cheaper at home. It would be better for the child to be home with their family. How can we make this work? So that was the first waiver. Right around the same time, DDA was around the same time. So each waiver is looking at a specific population and what can create that population to be able to live in the community and not in an institution. So each waiver is set up a little different. Sometimes it's more focused on the services that you can get, and sometimes it's more focused on the eligibility. So for model waiver, it's more focused on who can be eligible for it so that they can get Medicaid in the community. Most of these individuals, because it's still for people who would not qualify for Medicaid in the community, but would if they were living in a hospital, which we don't really allow anymore. So it's more preventative. So it's a smaller program, and most of these individuals have private insurance, but their private insurance doesn't cover everything they need in the community, specifically, usually 9 times out of 10, skilled nursing care. So private duty nursing, shift nursing. Most insurances will pay for a skilled nurse to come out and make a visit. But if they pay for shift nursing, it's usually very short term. So model waiver, the eligibility is under 22, so 21 and under when applying. If you're still eligible once you're in, you can stay on. Most people, I'll get to that in a minute though. So 22 when applying, under 22. Medicaid application is based on the child's income and assets only. They would qualify for skilled nursing facility level of care or chronic hospitalization. They would need model waiver services to remain in the community. And those needs cannot be met by other Medicaid programs. And those needs cannot be met by their insurance. So it's mostly children. Typically, when someone in model waiver turns 18, they would apply for SSI. So SSI, until you're 18, is also based on the family income. When you're 18, even though you might still be living with your family, it's only based on the individual's income. So when you get SSI, that gives you Medicaid, and most of the individuals will then qualify for REM. So what is REM? REM started when Medicaid moved from fee-for-service to managed care. So fee-for-service, you go to the doctor, they bill Medicaid. Everybody bills Medicaid. Nursing bills Medicaid. And in 1997, they're like, yeah, we're not going to do this anymore. We're going to pay managed care organizations to have a network of providers. They're going to do the claims, pay the providers, and we'll pay them to do all that. But they knew that there was these high cost users that they were aware of that had lots of specialists and lots of services. So they could have 8, 10 specialists, nursing agency, equipment company, physical therapy. And if you were going to force them into a managed care organization, because each one is going to have their own network of providers, chances are they're going to have to switch half their providers. They're going to take probably the physician that's most important to them based on their diagnosis, choose the managed care organization that that physician's in, and then they might have to switch most of their other providers. They didn't want that to happen. So they came up with a list. They started with rare diagnoses and then added more later that were not rare, but were expensive. So there's a list of over 300 diagnoses. If you have community Medicaid and you have one of those 300 plus diagnoses, and then each diagnosis has an age range for when that diagnosis is expensive. And if you're within that age range, then instead of going into managed care, you can be in the REM program and use any Medicaid provider and get case management to help you navigate Medicaid. So the list of diagnoses are, you can either scan that or click on that link, but they're the diagnoses. That's what qualifies you for REM. Next slide. So community first choice and community personal assistance services. These both fall under that umbrella of what we call community first programs. So CFC is intended to prevent adults, but they made it for all ages, from going into a nursing facility. So back in 2013, I believe it was, there was a younger adult waiver and an older adult waiver, and it was all trying to discharge people from nursing facilities into the community. They combined them together and they created the community options waiver, which is probably on the next slide. And when they did that, they realized through these waivers that as we were emptying beds, they were just filling them right back up again. So they wanted to prevent people from going into a nursing facility. So that was the intention of this. So, but they made it for all ages. You would reside in the community with community medical assistance, and you would qualify for skilled nursing facility level of care. You don't need to be in a skilled nursing facility, but you would qualify for one. So this was intended to prevent people from going into nursing facilities. The way these roll out, there are people coming out of nursing facilities with CFC because they're the services that they need. They don't need any of the CO services. But that was the intention of this program. And then community personal assistance services has been around as medical assistance personal care for many, many years. That was run in the health departments, the local health departments, when they were creating this umbrella of personal assistance services as the main service in community options, CFC and CPAS. So when they were creating them, they pulled that under the same umbrella so that everyone receiving personal assistance services were paid the same way. So that's for all ages. They reside in the community. They have community medical assistance, and they need assistance with activities of daily living. They don't have to have a skilled nursing facility level of care, but they do need a level of care that requires assistance with activities of daily living. Next slide. So the community options waiver, the intention was to discharge people from nursing facilities, adults over 18. So again, now there's people in the community who have put themselves on a waiting list, or what they call a registry. and they're opening up that registry. So there are people from the community applying for this, but the intention was to discharge people from a nursing facility. So it's for individuals 18 years old and older, qualify for a skilled nursing facility. If not currently, then their name is on a registry, but they would still have to qualify for that level of care. And then the financial eligibility for medical assistance. They typically have, if they qualify in the skilled nursing facility, they qualify, but it's a little bit more lenient. There's a spousal impoverishment formula. So if you have a spouse at home, they don't necessarily have to meet this criteria, but there is financial eligibility for it. So that's the community options waiver. The brain injury waiver, the brain injury occurred after 17 years old, and they're currently inpatient in a state behavioral health administration facility or a Maryland licensed special hospital for chronic disease that is CARF accredited for brain injury and patient rehabilitation, or individuals who've been placed out of state by Medicaid. There's also the same financial eligibility as a community options waiver, but that criteria, you have to be in there and it's after 17. We don't do the brain injury waiver. It's fairly small, so I don't have as much knowledge about that one. Next slide. DDA. So to qualify for DDA, when you fill out your application, you start on a wait list. So to qualify, you're a resident of Maryland and you have a disability. And how they define a disability is it's likely to continue indefinitely. It manifested when you were under 22. It results in an inability to live independently without external support or continuing and regular assistance. So you would not be able to live independently without this support system. And it reflects the need for a combination and sequence of special, interdisciplinary, or generic care, treatment, and other services that are individually planned and coordinated for the individual. So that's what they look at when they're determining eligibility. And then getting onto the waiver is typically transitioning youth, so they're exiting school or they're in crisis. But most come on in transitioning youth at 21 years old. So the autism waiver is, again, another one of those waivers, obviously for individuals with autism who would be institutionalized. So it's moderate to severe. So their school age, they must meet an institutional level of care for ICF-ID, intermediate care facility. They must have an IEP with 15 hours of special ed and related services. And that's where that moderate to severe autism is. It's not for the higher functioning. And they recently changed the level of care that's a little bit more strict. So it really will be for moderate to severe. And then there's financial eligibility, which is based on the child's income only, similar to model waiver. Next slide. And then the last one, this is our newest one, the medical daycare services waiver. So eligibility for that, there's been a waiver, but there wasn't independent case management until this March. So to be eligible for the waiver, you're 16 years old or older. Now, the medical daycare services is also in each waiver. So you can get it in each waiver. And if you're not already in another waiver, you would be in the medical daycare waiver. So it's 16 years old or older, must meet a skilled nursing facility level of care, and they do that through the NRI or an ADCAPS assessment. So that gets done through the health department at first for the initial eligibility. Financially eligible for Medicaid, so you have to be eligible for Medicaid first, which is a little different than some of the other waivers. A documented need for medical daycare services, and they need an order from a physician. Participate in a person-centered plan development, a plan of service. Reside in a home or community-based setting that qualifies with the final rules. So it has to be, you wouldn't live in a nursing facility and go out to the medical daycare. It has to be a home or community-based setting. And then eligibility is reassessed annually. So you can see the ages are model waiver, it's 21 and under. Community options waiver is 18. This is 16. Brain injury is 17. So that creates a lot of overlap or areas where people fall between the cracks. Next slide. So the direct care that someone would receive in each one of these programs. In REM and model waiver, you would get you have a skilled nursing need, and you would have private duty nursing. So that would be a shift of nursing. That's typically, tracheostomies, ventilators, G tubes with continuous feeds or frequent feeds. So that's skilled nursing need. The Community First program, so the CO waiver, CFC, CPAS, the main direct care service that you get is personal care services. So that would be no skilled nursing needs, or their needs that can be delegated by a nurse. They couldn't delegate suctioning a trach, but they could delegate activities of daily living. And then there's some gray areas in between there, but it's up to the nurse. And then DDA, autism waiver, and the brain injury waiver is more supports and community integration services. So that's the difference between the direct care services that you can get in each one of these programs. Next slide. So how could you be eligible? Let's say we see often somebody who has a list of diagnoses. They have a lot of medical diagnoses and sometimes also have an autism spectrum disorder. So do they have skilled nursing needs? They could be eligible for model waiver or REM or medical daycare services waiver. They could be eligible for REM based on one of their diagnoses that creates the medical need. And maybe they don't need skilled nursing needs. They might still be eligible for REM, but model waiver, medical daycare, they would need some kind of that's nursing need. Complex medical needs, but no nursing needs. So they could have a lot of diagnoses, but no skilled nursing need. They don't have a tracheostomy or a G-tube or anything like that. They could get personal assistance services through CFC or CPAS. And the developmental needs, they could get autism or DDA. So that's how somebody could be in, and I have a screen where I show you the different combinations. REM, CFC, and the DDA waiver, or maybe the autism waiver. Let's say somebody became quadriplegic at age 16. So there's one of those ages that falls into several areas. If they have skilled nursing needs, depending on where the level of injury is, they could qualify for model waiver. Quadriplegia is a REM diagnosis, so they could qualify for REM. The difference would be whether or not they have community medical assistance, and they could qualify for the medical daycare services waiver. If they have no skilled nursing needs, so they're not on a ventilator or anything, they could qualify for CFP services. That should say CFC or CPAS, but the CFP programs. And disability prior to 22, they could qualify for DDA. So they would not qualify for the community options waiver because you have to be 18. That's where those ages come in. But that's how you could be eligible for various programs. Next slide. Limitations. So you cannot be in more than one waiver program. So you can't be in model waiver and autism waiver. You can't be in the DDA waiver and the medical daycare services waiver, but you could get medical daycare in the DDA waiver. So you can't be, sometimes people are on the community options waiver and then they become eligible for the DDA waiver. Then they have to make a decision on which waiver they want. And you cannot be in more than one of the support planning programs, or what we call community first programs. You can't be in community option waiver and CFC, or CFC and CPAS. You're in one of them, and you cannot be in both model waiver and REM. The services you get in there are almost identical, and model waiver was in place before REM. Waivers that came after Sometimes they get their Medicaid through the waiver, and then instead of going into an MCO, if they have a REM diagnosis, they might go into REM. So they're the limitations. Common combinations, you can be in the community options waiver and REM. We have discharged people from nursing facilities. They come onto the community options waiver. That gives them Medicaid, and then they have to make a decision on which MCO, unless they have Medicare. Medicare, you don't go into health choice, so you would not be eligible for MCOs or REM. So you get your Medicaid, you don't have Medicare, and you're choosing how you're going to get your Medicaid, one of the MCOs or REM. If you have a REM diagnosis, then you could get your Medicaid through REM. So that's how that would happen. CFC and REM, it could happen the same way. You could be in REM and we tell you about CFC because maybe you need services that are in CFC. You can still keep REM. You get case management, you get the flexibility of using any provider, and you can get other services in CFC that are not in REM. You can be in CFC, REM, and DDA. We've had that. And when they get onto the DDA waiver, they can stay in both REM and CFC. That's where it gets hairy as far as who's providing the direct services. You can be in CPAS and REM, just like CFC and REM, it would happen the same way. You could be in CPAS, REM, and DDA. You could be model waiver and CFC and model waiver and CPAS, but not model waiver and the CO waiver because they're two waivers. You can be in CFC and a DDA waiver. You can be in CPAS and a DDA waiver. And you can be in the brain injury waiver and also have REM, CFC, CPAS. You could have brain injury, REM, and CFC, but only one waiver. Next slide. So the advantages is they have different services offered in different programs. So let's say you're in REM and maybe you do need skilled nursing. So you're getting your direct care service through REM, but CFC offers environmental adaptations and assistive technology that in REM, we would have to look for community funding for that. So maybe you go in CFC just to get those. DDA covers vocational and residential. So you could be in REM, be on the DDA wait list. When you're exiting school, you could have access to vocational services and group home and residential services. So that's where you could be in different programs and get different services that are not offered in other programs. You also might have different needs at different times of the day. So if someone has a skilled nursing need, if the family is not there, they would have to have a skilled nurse. If they have needs that cannot be delegated. But maybe the family's there, but they need assistance with activities of daily living because maybe the parent, the primary caregiver, can't lift the person by themselves. So then they would need probably CPAS services or CFC to help with activities of daily living. You might have skilled nursing needs at some point during the day and not at other points during the day, depending on what goes on when you sleep. Maybe you have a G-tube running all night, you eat by mouth during the day. So it depends. People have different needs at different times during the day. And family friends can be providers. They cannot do that in skilled care, but in CFC, you can hire to be your personal assistant services, a family or friend, but they have to work for an agency. In DDA, you can hire a family and friend and have self-directed services and just put them in your plan. So, but you cannot, there still cannot be skilled care that's provided by these if they're being paid by Medicaid. So that gets confusing when a mother can provide skilled care because they're trained to take care of the trach, but as soon as we start paying them, they're functioning as either personal supports or a personal care attendant, personal assistant services. I use them interchangeably. So you can't delegate that. So when they're being paid, they cannot provide the skilled care. When they're functioning as the parent, they can. So that can get confusing. But they're the advantages of being in multiple programs. Next slide. Some of the challenges is which program will provide what. And some of you may have been in this situation where there's bad. I think when there's a skilled need, it's usually pretty clear. But there are times when, well, I've seen one where someone has a trach. So other programs think that if you have a trach, you automatically need nursing. If you can manage your airway yourself, you can cough. You don't need to be suctioned. We don't need to be assessing your respiratory status, that trach is just there for a physical so you can breathe. You have a blockage up or you need it for a ventilator at night or something like that. But just because you have a trach doesn't mean you need nursing. So I've seen other programs say, nope, you need a nurse. And that's where the programs need to come together and communicate with each other. So sometimes it gets confusing about which program will provide what. It really gets confusing, I'd say, with DDA and CFC, or Community Options Waiver, and CPAS, where you're using that personal assistant services, because that's activities of daily living. And DDA is really about meeting certain goals and integrating you into the community. And that could be fuzzy about what's happening at what time during the day. I would say I would put on my task schedule the primary reason for services at that time. So if it's to get up in the morning, get showered, out of bed, get your breakfast, that's more personal assistance services. And now you're going to go out into the community and there's somewhere that you want to go every Wednesday. Maybe you go out and you play bingo at a center every Wednesday. It's possible that when you're playing bingo, that you might have to go to the bathroom and you might need help. So that's where it overlaps. But to me, the primary reason you need someone at that time is to integrate into the community and meet your goals. So it gets confusing, and the programs will kind of deny this and tell you to get this elsewhere. And that's where we have to bring the programs together to decide what. But I think if you make it really clear on the task schedule, skilled needs cannot be delegated. That gets very confusing when you're in other programs, like when you're trying to get services not in REM or model waiver. DDA, CFC, community options, there's a nurse who's delegating that, and they can only delegate so many things or certain types of skills. And you might need a certification in delivering medication for some. So that gets confusing because family members feel like, well, I can do that when I'm a family member, but once we start paying you and a nurse is delegating, they can't delegate that skill. Sometimes you lose other services. So if you apply for one program and they say, well, if you can get personal assistance services during that time, you should be able to get them anytime. So you may not need nursing anymore. So you risk maybe losing services if you're saying your needs can be met by a different service. And confusion. It's just very confusing. I think this is the last slide. Questions?
Right. I see the first one is any assistance to help parents on the autism waiver appeal process on the LOC.
Any assistance in the appeal process. So if you've already filed your appeal, I would call, if you can't afford a lawyer, Disability Rights Maryland might be able to help you. I don't know which cases they take, but they did change that level of care. So I'm assuming maybe you didn't get the level due to the new screening tool. But I would try Disability Rights Maryland. Parents Place has parents now, again, because this is new, you're probably not going to have someone who's gone through that. So more the legal way is probably the better way to go. Sometimes if it's something that other parents may have been through, Parents Place can sometimes